Okay.
भी आया चला गया
Are you complete? Okay, so let's start. So for this afternoon, we will have our um, small group discussion on normal labor and delivery. So this SGD aims to walk you through in what normal labor and delivery would look like at the hospital when you do your clerkship. So we see a patient at the ER and then we will manage this patient until the patient delivers. All right. So um, let's start. Okay. So at the emergency room, you see a 23-year-old Gravida 3 para 3. I'm sorry, that's Gravida 3 para 2, my bad. Came in with a chief complaint of regular uterine contractions. So you are the clerk at the emergency room. So how will you manage this patient? What are the questions that you would have to ask this patient? So
um, we
like,
ask the we
okay,
ask the intensity, frequency, and duration between the contraction to check
okay,
for the true labor.
okay. One is to ask for contractions. Okay, what else?
When we ask any watery discharge or
Okay, if there is any watery or bloody discharge experienced
Ma'am,
by the patient. Okay, what
doc,
else
it
is
doc,
important
it is
information?
important to ask for age of gestation and age of confinement to know that it is a preterm, postterm, or
Okay,
end-term
so
labor.
first thing to establish at the emergency room would be the age of gestation of the pregnancy, and that is obtained through either your last menstrual period. How else could you determine age of gestation?
We ask about the last menstruation period, and from
Yes.
last LMP to the present date, count the day and divide it by 7. So we can uh, get the how many week of the age of
Okay,
gestation.
your last menstrual period could give you your age of gestation and your expected date of confinement. Those computations are basic competencies in your clerkship. Okay, so for example, your patient does not know your LNP, your age of does not is unsure of her menses. How else could you establish age of gestation?
By
Doc,
ultrasound.
by ultrasound also, and fundic height.
How could you one is by ultrasound? If patient does not have ultrasound, how could you check age of gestation through fundic height? What do you
Doc,
know about fundic height and age of gestation? How does it correlate?
doc, at the different part of the different time of the pregnancy, the fundic height will change. So by uh, palpating the uterus on the by abdomen, we can obtain the age of gestation, approx age of gestation.
Fundic height, how does it correlate? Anyone?
Hot dog.
Yes, Yash. How will your fundic height correlate with your age of gestation?
Ma'am, Fundic height shows the age of gestation by gestational age week. Like if 12 to 14 weeks, fundic height will be at the pubic symphysis. Then increasing by 20 to 22 week, 10 mark is at umbilicus. Then
Umbilicus is at how many weeks? Estimate.
22 weeks, doc.
20 weeks? Up to 22 weeks, okay. And then?
And then at the xiphoid process of sternum at 36 to 40 weeks.
Okay. So, at around 20 to 30 weeks, it's more or less corresponding to your age of gestation. Okay. How else? How else would you determine established age of gestation without knowing the LMP and just examining the patient? Yes.
Well, you can use the number of the trimester the patient currently is, and then you mark the current date, and then you calculate the number of days from the last trimester to the current date, and then divide by 7.
Okay, that's your um, AOG computed through your LMP. Okay. Aside from your fundic height, other what are your other indicators so that you will know your age of gestation?
Ultrasound product.
If your ultrasound's been given, your LMP, fundic height, what else? Remember your obstetrics one.
Doc, with abdomen circumference and by which we can measure the weight of fetus, and also by parietal diameter.
That is biparietal diameter would be ultrasound parameters. Anyone? So, well and good if your patient would know your LMP always, but that's not always the case. So, you have to have something to fall back on. So, one indicator, you're correct, ultrasound, but not everyone would have the benefit of ultrasound always. More often, your patient will come in labor, no checkup, etc. Sometimes not knowing date of menses. So, one, you could assess by fundic height. What else? What else could you ask the patient so that you could estimate age of gestation?
Last while taking the approx days of the menstrual period cycle, last three
Yes, your patient is
last
unsure. Fundic height is one. Okay, what else?
Doc,
Yes, Edwin,
Doc,
on its
if we could get the trimester in which the patient is, for example, let's say the patient has done as is in the first trimester, so we If we can get that date, we'll mark the date of that first trimester, which is usually 11 weeks. And then we calculate from that date until the present day that the patient is at the hospital. So we add the number of the days to that particular trimester to get the full days. Then we can still divide it by 7 to get the actual time.
And also we can measure age of gestation during third trimester by measuring head circumference and the femoral length. Most of femoral length is most
Those are ultrasound parameters by parietal, head circumference, femoral length. Okay. You will not always have the benefit of ultrasound. Okay. So how will you know if patient is term or not, or at least estimate? Fundic height is 1. What else do you ask the patient? Remember your obstetrics 1. You know this. You will beat yourself up for not knowing the answer. What do you ask the patient?
Ma'am, can we ask the date of the pregnancy test?
Date of pregnancy test. What else will you ask?
Dating based menstruation history. Doc, dating based menstruation history.
Your patient is unsure. Okay. You ask for quickening. What is quickening? For taking so long. What is quickening?
It is the perception of the fetal movement by the mother.
Okay. So you ask, when did the patient first feel fetal movements? And when would that be? So if that patient is able to answer, of course, not all will be able to answer the question. So there are a lot of other things that you could ask. But if the patient is able to answer that I was able to feel this at a certain point in time, you will know that at that point in time, around how many weeks or she would be in age of gestation.
around
When
18.
18 week product.
18 to 20 weeks.
Okay. Remember, this is a gravidity patient. So she has been pregnant before. So she will feel fetal movement earlier than your gravid. Okay. So again, you have to know what questions to ask. And it's not always, the patient always knows her first day of LMP. Because more often than not, it's not the case. Or patient has irregular menses. So she really would have no recall on how long was it ago. For example, those are things that could happen. Or, for example, patient just delivered a baby, did not have mens but is pregnant again. When was the last mens? So it was for the other pregnancy. It happens. Patient gets pregnant, did not even have menstruation for the second baby. It continued. So those are things that you have to be ready for, and not always LMP. That's not to the LMP. Oh, I have my ultrasound. Okay. So for example, another thing, your last menstrual period and your ultrasound is not congruent. It is more than 2 weeks apart, or shall I say 2 weeks apart. What will you follow, or how will you resolve this issue? If it's within 2 weeks, okay, follow your last menstrual period. Okay, because as you know, it is always plus or minus 2 weeks in obstetrics. Okay. But if it's more than 2 weeks apart, what should you do? Then you have to validate. As for another ultrasound, then look at which is nearer. Is it nearer the LMP? Is it nearer the ultrasound? Then that is what you follow. Usually, if it's not congruent, usually it follows the first ultrasound and not the last date of menstruation. Okay. Anyways, okay. So if you've established age of gestation, you ask for watery discharge, you've asked for contractions. What else do you have to ask this patient?
Past medical history, and also check of familial genetic disorder for asthma and
Okay,
diabetes.
you have to ask for past medical and family medical history. Okay, what else?
Any complication during pregnancy?
Any complications? She has had 2 pregnancies. Any prior complications that she has had experience? That's correct. What else?
Doc, we can also ask for is the pain is radiating to the back or thighs or not, so we can differentiate it is true labor or false labor.
Okay, painful contractions. Yeah, intensity, duration, as mentioned by your classmate, so that you could differentiate true and false labor. Okay, how do you differentiate the two?
Doc, if it is radiates to back or thighs, then it is true labor, but in the false labor, it doesn't radiate. At the same, in also for if the mother is already in the active phase, if we give like for example sedatives, if the mother is in the true labor, it doesn't. Uh, it doesn't cause effect on mother, but if it is false labor, then it will work.
Ma'am, also the false labor is the irregular and usually it is the weak compared to the true labor.
Okay, so true labor, it becomes more intense, it becomes longer, frequency becomes more, um, frequency increases. As to false labor, also known as your Braxton Hicks, okay, which is more of related to movement. What else? What else should you establish in this patient?
Ma'am, we
Doc,
check the vital sign,
Okay,
check the
vital
fetal heart
signs.
rate.
Okay,
Doc,
fetal heart rate
you
should be
would like
documented. Yes, go ahead.
yeah you would like to ask the patient if it's the first time she's giving birth or if she already gave birth before.
It's stated it's gravida 3, but of course you establish previous pregnancies, the route, okay, the outcome, etc., etc. If she had a difficulty of labor, okay, that's correct. What else?
Until
We can
History
ask
of
pregnancy.
for any drug
vaginal.
history, ma'am.
One by one, please.
So can we ask for a drug history if patient is taking any medicine or not?
Okay, drug history.
And also social history,
Okay, social
like
history. Okay,
oh,
alcohol,
alcohol or smoking, any bad habits.
etc. Okay. Are you happy with your history? Are your questions complete?
Of amniotic fluid leakage,
Okay, watery discharge already been
and
asked.
to differentiate false labor and true labor, we can inspect the cervix. There is no change in cervix in false labor, whereas the in true labor cervix will become softens and shortens and also dilates.
Okay, then what would you look for in your physical examination?
Ma'am, we are doing the internal examination and look for the cervical dilatation, cervical effacement, cervical consistency, cervical position, and fetal station.
Okay, you are looking at that to establish what score.
And ma'am, for the physical examination, during we will
No,
do the
those
general
ID
systemic.
parameters would give you what score?
Bishop score.
Bishop score.
Your
Bishop
Bishop
score.
score. Okay. Anything more than 8 is a favorable score, which is more or less okay.
9 dog.
All right. Um, although this patient already delivered, what else is important in your internal examination? What else do you have to assess?
Vital signs.
You went straight to your internal examination. Aside from your bishop score, what else is important as you do your internal examination?
Fetal presentation, doc.
Okay, your fetal presentation is one. More or less, if it's already dilated, you would feel the fetal head. What else? What else do you have to assess for when you do your internal examination?
Discharge, cervical discharge, doc. The vaginal discharge, most probably brownish in color. In post labor and intra labor, it's a mucus discharge with a small to moderate amount of blood.
What else? When you do your internal examination, you assess for bishops. Okay, that's your dilatation and your other bishop score parameters. And what else is important as you do your internal examination?
Is it to check for the fetal position?
Okay, fetal
Doc,
position, you could
doc,
check that it's cephalic and it's more a function of your abdominal examination in your Leopold's. Okay, what else would your internal examination
doc,
give
we
you?
can check for pelvimetry.
Okay, we always tend to forget our clinical pelvimetry. Okay, how do you do your pelvimetry?
We check for the diagonal conjugated. We first measure our length of the finger, then two finger of the examining hand are placed in the vagina and pressed inward and upward until the middle finger touch the circle prominence.
Okay, so you reach for your sacral promontory, and that would assess your diagonal. Okay,
Inadequate.
and what is
Yeah.
the parameter that is your? I heard it. It's inlet. Okay, so you check for the adequacy of your inlet. After checking for the adequacy of your inlet, what else will you check for?
The cervical consistency and cervical
We
assessment.
are still at our pelvimetry. Okay,
Ma'am,
how
we
will you
check
assess your midplane? What are the 4 parameters of your midplane?
in mid plane. We check the circle curvature, ischemic spine, pelvic side wall, and sarcoschiatic knot, ma'am.
So you have your hollow sacral curvature. Okay, your sacrosciatic notch admits 1 to 2 finger breadths. Side walls should be
Divert.
diverted, not convergent. Okay, and your what's the fourth one?
Ischemic spine.
Your ischial spine should be
Prominent.
non-prominent. Okay, if it's prominent, it might obstruct. Okay, so that is the midplane. What are the 3 components of your pelvic outlet?
Is the bituberous diameter, pubic arch, coccyx, and the sarcotuberous ligament.
You have your 3. You have to have a movable coccyx. You have a bituberous diameter of at least admits a fifth or 8 centimeters. And your pubic arc should be more than 90 degrees. So that is your adequate pelvimetry. If it's anything less than that, it's doubtful. Yes, but you still do your clinical judgment if you will allow trial of labor. Okay. So remember. So how would you examine the abdomen? So how will you do your Leopold's exam?
Ma'am, in Leopard Maneuver 1, identify which fetal pole will occupy the fundus. In Leopard 2, perform the determine the fetal lie. In 3, determine if the presenting party is engaged. And in 4, differentiate the anterior shoulder.
So Leopold's 1, you check if there is a head or a breach in your fundal area. Okay. What would Leopold's 2 check for?
Umbilical grip.
Is fetal lie.
Okay. So what is the importance of your fetal line? If
If it
your
is
fetal back is at your right, where will your fetal heart tones be?
In second maneuver, doc, at the site of back, we can feel the heart rate.
Okay, your heart rate would be at the same side as your fetal back. What's your third Leopold's maneuver?
Ma'am, we can palpate the breach presentation.
Okay, it's a confirmatory of your fundal grip. What is it called? Your Leopold's 3.
Pollic grip,
Pollick's grip. Pollick's grip.
Pollick's grip. Okay. And then what is Leopold's 4?
pelvic grip,
Pelvic grip.
And what does it check for?
Degree of extension of fetal head or breach in the cervix.
So flexion or extension as the head goes into the cervix. Are you happy with your history and physical examination?
Mostly, doc.
Mostly, yes. Okay. So these are the results that you got. Sorry. Really. So your fetal heart tones is 150 cephalic floating. Contractions 1 in 30 minutes. So internal examination is 2 to 3 centimeters, 50% effaced, midline, soft, station -2, but ruptured bag of water. What is your next best step? I'm sorry.
We admit the patient, doc, and induce the patient.
Okay. We admit the patient for labor induction. Okay, what is the basis of your decision, of your clinical
uh,
decision?
dog, because mother has already ruptured back of water. If and she has only 2 to 3 centimeter cervix dilated. So if we will wait, it will take more hours to get her into active phase of labor. It can cause her infection. That's why.
Okay. So your ruptured bag of water signifies that you have to admit the patient because you more or less have 18 hours to deliver this patient. Okay. So we admit this patient for labor induction. What's the difference between labor induction and labor augmentation?
Doc, in labor in the labor induction means patient is already have some contraction, but in the augmentation of labor, patient mother doesn't have a contraction. So for example, if
Isn't it
patient
the other way around?
yeah, doc,
Induction,
yeah,
you don't have
for
contraction.
yes, doc,
In augmentation, you have a little contraction, and you
contraction.
would just have to increase it. Correct. Okay. So you admit this patient and you do a non-stress test. Okay. What is a non-stress test?
It is used for fetal monitoring.
Okay. It is
Uh,
your antenatal in labor fetal surveillance. Okay. What are the components of your non-stress test?
Doc
Fetal
is
heart.
heart rate, uterine contraction, acceleration, and declaration.
One is, I think you're missing one. Okay, one is your
If
heart rate.
Bit to bit
What's
variation.
the average? What's the average heart rate?
110 to 160.
Okay, 110 to 160 is acceptable. Okay. I've heard the other missing component. It's your beat-to-beat variability. So you have your minimal, marked, and moderate. Okay. So usually variability would range from what? 5 to 25 beats per minute. Okay. Then you have your acceleration. So that is defined in the slide. Acceleration increase of greater than 15 bits per minute more than 15 seconds. Okay. Your deceleration decrease in 15 bits per minute more than 15 seconds, and we will have different decelerations. Okay, and your uterine contractions. Uterine contractions would be measured in what units?
Montevideo units,
Okay,
doc.
it is measured in Montevideo units. For you to tell that it is adequate, it must reach how many Montevideo units?
Around 210 to 250.
Okay, it must reach 200 Montevideo units. Okay. An adequate contraction would be how many contractions in 10 minutes?
Three contraction in 10 minutes.
Okay, you have to have 3 contractions in 10 minutes. Okay, am I just talking to 2 persons, to Ruth V and Naiti Ben? Where's the others? And Eliseneku? Where are the other students? Let me hear from them. You 3, stop answering first. Okay, you're good so far. Okay, so that is your non-stress test. So this would show that the fetal status is good, etc. So what is your next best step? How will you manage this patient? Okay, your classmate has mentioned induction. How will you induce this patient to achieve better contractions?
Doc, is it by administering oxytocin to aid contraction?
Okay, you administer oxytocin to hasten the contractions. Is it there? Okay, you incorporate it in 1 liter. You start at 8 to 10 drops per minute. Take to achieve contractions of how many? 2 to 3 minutes. Every 2 to 3 minutes. Okay. For example, you are inducting this patient and you noted that contractions occur every 2 minutes, lasting for more than 1 minute, and very intense. What will you do? What is this patient experiencing? So for anything that will involve oxytocin or labor induction, you are wary of this happening.
Hyperstimulation.
Okay, that is hyperstimulation. Who is that?
Shaluda.
Okay. Hyperstimulation. So how will you counter this hyperstimulation so that your baby will not get endangered? Of course, if your uterus contracts for very long, your baby would have limited oxygen. So how will you counteract this hyperstimulation?
We will stop oxytocin.
Okay. Number 1 is stop your oxytocin. What else?
Wash it with water.
Okay, you hydrate or wash it with water. Okay, what else?
Doc, subcutaneous administration of terbutaline.
Why will we give terbutaline?
Doc, put patient on oxygen.
Okay, we hook the patient to oxygen. Okay, what else?
In left lateral position.
You put the patient in left lateral decubitus. And what else?
Doc, terbutaline used to decrease the contraction, doc.
Okay, we stop
Slow the contraction.
decrease contractions. What else?
Then vibroacoustic stimulation.
We stimulate vibroacoustic. We used to have a bell, but now the clerks just use the smartphone, put it on the tummy to do vibroacoustic stimulation.
Doc, wash out oxytocin.
Yes, we withhold the oxytocin. Okay. So for induction, we give oxytocin. Okay, what else? How would you monitor this patient?
Doc, we check the fetal heart rate every 30 minutes.
Every 30 minutes. If it's in active phase, after 30 minutes
Monitor
per
by
stage of
strict fluid
labor.
chart.
If the patient is in active stage of labor, how often do we have to monitor the patient? Fetal heart tones wise.
Every 15 minutes, doc.
15. Okay, OB normal. Okay. Estimated time of delivery of this patient. This is a multigravid. Patient is currently 2 to 3 centimeters. In how many hours will this patient deliver?
2 hours, doc.
Is it 2 hours?
4 hours, doc.
How
Doc.
did you arrive at the answer? Your
After
multigravid dilates at how many centimeters per hour?
Ma'am, our patient is multipara, so he
4.5
1.5
hours.
centimeters.
One by one.
to 1.5 centimeter.
One by one. So your multipara dilates at how many centimeters per hour?
1.5 centimeters.
1.5 centimeters per hour. So if this patient is currently 3 centimeters, so how many hours?
1.2 to 1.5, doc.
1.2 to 1.5. Your 1.2 is for your primigravid. Your 1.5 is for your multipara. Okay. So for if this patient is 3 centimeters, in how many hours will this reach your 10 centimeters? Will become fully dilated?
Around near 5 hours.
Around
Near 5 hours. 4.5 to 5 hours. 5 hours.
4.5 hours. Okay. So as we have mentioned, to augment the labor, we use oxytocin. Okay. Other labor augment other things that we do to augment the labor would not be found in your Williams. So nowhere will you see your Buscopan to augment the labor or your other things that we do at the delivery room. Okay, so it's oxytocin. Okay, how would you deliver the baby? Okay, if it's within 18 hours, you have your vaginal delivery. Okay, what are the cardinal movements of labor? Let me call all.
Doc, engagement.
Doctor engagement.
What? Wait, let me call. Who hasn't spoken up?
Engagement. Hello, doc.
Doc engagement, descent.
Okay.
Flexion,
flexion,
internal rotation,
external
extension,
rotation,
and
expulsion.
extension, and
expulsion.
external rotation and expulsion.
So if that occurs, then you would have your vaginal delivery. So how will you, so that's the physiology of your cardinal movement. But what are the steps in doing your spontaneous vaginal delivery? So visualize. So your baby is at the introitus. Baby is crowning. What will you do? Okay, one by one, and you answer. Okay, Rutu, what's the first step?
Ma'am, the first step will be engagement, then descent.
No. We're done with the cardinal movements of labor. We are in the clinical aspect of doing a spontaneous vaginal delivery. So you are there as the main surgeon. Your baby is crowning. Your labia is paper thin. Okay, what do you do?
Can we cut the
Ma'am, we will check for crowning.
Okay, and then?
And then for episiotomy.
Okay, how will you perform your episiotomy? Om Prakash, thank you. Luto.
Yes, doc. We will do the episiotomy medio and mediolaterally, doc.
Okay, you
Two
have your
types of.
median and your mediolateral episiotomy. What's the advantage of your median episiotomy?
Doc, it's prevent the damage of the anal sphincter.
Median. That is for mediolateral.
Yes, doc, it's mediolateral.
Okay, and that is the only advantage of your mediolateral. Prevent your fourth degree, your damage to your rectal sphincter. But for me, that's the only important advantage. So, I prefer mediolateral. Anyways, okay. So you do your episiotomy, you insinuate your two fingers and then cut either median or mediolateral. Once you have cut, what will you do? Shadow is done. Patel, may I hear from you?
Yes, doc.
What's next? You have already done your episiotomy. So what will you do?
Doc, put two finger over and under the neck. After the episiotomy cutting, we have to put two finger over and under the neck.
Okay. But that's already head delivered. Okay, what do you do?
Place one hand on the baby head.
What do you what maneuver do you do so that you would have controlled delivery of the head part?
Doc, Ritget's maneuver.
Okay, you do your Ritken's maneuver. So your assistant will have your gloved hand on your where? Could you describe the Ritken's maneuver?
Adrian, can you turn off your mic?
Okay. So how will you do your Ritken's maneuver?
Me, doc.
Yes, go ahead.
For
Fetal chain is reached between anus and coccyx and will be pulled anteriorly, ma'am.
Okay. And then where's your other hand? It's on your
And why on fetal occiput to control the speed of delivery. And we will keep flexing of the fetal neck.
All right. So that's you will not have further lacerations. Okay. What's next? Yash. How will you deliver the fetal head?
Doc, when the head descend the vulva and peritoneum to open the vaginal diameter, it's more than 5 centimeter or more. One hand of the towel drap and a hand may be extract forward pressure on the chin of the fetus throughout the perineum just in the front of coccyx, and other hand are extract the pressure suppress again the occiput, dog, and then we deliver the head, dog.
In not so technical terms, you deliver the head how? With controlled traction, okay, you aid your external rotation. So when your baby starts to come out, it's not in position. So either you rotate left or you rotate right. You will feel it for whatever feels natural for the neck of the baby, it will naturally follow your direction. Okay. So your baby's out of your introitus. What will you do next? Patel
Yeah,
reading. Reading.
we will pull out the one shoulder and
Where will you
after
place
that,
your fingers?
what, ma'am?
Where will you place your fingers?
In the neck, ma'am.
Okay, you put two fingers on either side of the neck, and then what will you do?
We will deliver anterior shoulder and then posterior shoulder.
You pull downwards to deliver the anterior shoulder, and then pull upwards to deliver the posterior shoulder.
Posterior shoulder.
Once you have delivered the shoulders, what will you do? Who else hasn't spoken? Milind, Patel?
Yes, doc.
After delivering the posterior shoulder, what will you do?
After delivery, posterior will after child comes out, we proceed to step 3, that delivery of the placenta.
You haven't delivered the aftercoming body. How will you deliver the aftercoming body?
Okay, doc. Babies after babies head and shoulders come out of after shoulder, we pull the baby's butt, and after that we proceed for cutting the umbilical cord as a final step after baby is completely out and has.
Describe how you will deliver the aftercoming body. Could you help Milind, Patel, Om Prakash?
The slide
Yes,
your
doc.
hand.
Okay. Om Prakash.
Yes, doc.
Okay. How will you deliver your aftercoming body?
No, doc. So after the shoulder will be coming out, then we will one hand thought out back to the body, and then slightly hand grasp the body feet, and then we will remove the.
Okay. Slide your hand up till you grasp the feet. And
Yes, doc.
then once you have grasped the feet, what will you do to the baby?
Skin to skin contact with mother, doc.
You put on the tummy and initiate skin to skin contact. What else? Milind, did you hear? Could you repeat what was said? How will you deliver the aftercoming body?
We will put our one hand on the back of the baby and grasp baby with with that hand and put it on mother's body. So skin to skin contact. So baby can skin to skin
What
contact.
else? What else, Milind, would you do for as soon as you do your skin-to-skin contact? This is also known as essential newborn care or the active management of your third stage of labor. What else will you do?
Then ma'am, we can go for final stage that delivery of cutting after that we'll cut
Before you
umbilical
cut
cord.
the cord, before you cut the cord, what are the components of your active management of your third stage? Okay, one is skin to skin, that is your early essential newborn care also. Skin to skin, what else will you do to the baby?
The baby.
What else will you do to the baby? Shallow.
We will first dry the baby.
Okay.
After that, we'll do the skin to skin contact, and we can do the properly and firm cord clamping. And then after that, the non-separations of the newborn and the mother for the early initiation of breastfeeding.
Okay. And the only thing that you forgot in your third stage of management would be administer your oxytocin, whether IM or you continue with your intravenous drip of oxytocin. Okay, good. So how will you cut the cord? Describe the process of cutting the umbilical cord.
From the 2 centimeter
First
and
clamp
the
the
5
cord.
centimeter,
Clamp
and
the
we'll
cord
clamp in
where?
between 2 centimeter and the 5
2
centimeter.
centimeters and 5 centimeters once the cord pulsation stop. Okay. You have clamped the cord, leave it with the skin of the mother. What will you do next?
Placenta delivery.
So you deliver the placenta. How will you deliver the placenta? Okay, what are the placental steps of separation?
Sudden gush of blood.
Okay, sudden gush of blood and then
Lengthening of
Rising
umbilical
of
cord.
the rising of
lengthening
the
of the
uterus in
umbilical
maternal
cord.
abdomen.
The uterus become globulous.
Uterus becomes globular and it rises
Rising of the uterus in the
up
maternal
into the
abdomen.
abdomen. Okay. That's your 4 placental sites. So you give controlled cord traction. Okay, believe me, it's easy to break. My first placental delivery, I broke the placenta. I broke the cord and left the placenta inside um, to the anger of my resident then. So she had to do manual extraction a bit. Anyways, so you do controlled cord traction to deliver the placenta. Okay. Okay. Once you have delivered the placenta, what will you do?
Check for the vessels of the placenta.
Okay. For the
2 artery and
placenta,
1
you
vein.
check for the vessels. Okay, if it has
2 arteries and 1 vein.
arteries and 1 vein. What else will you check for
And
the
placenta
Ma'am,
complete.
cotyledons.
if it has complete cotyledons? What else?
And lengthening of cord.
Okay. Okay. You have checked the placenta. What else will you check for?
Ma'am, we will check for cotyledons.
Okay, you have done your cotyledon check. What else?
Vagina.
reflection.
Okay. You check for your episiotomy. You check for your vaginal lacerations. If it is repaired, if it has lacerations, repair it adequately. Okay. How will you repair your episiotomy? Where do you start? Describe your episiotomy. Describe your episiotomy, please. Jill Patel.
Hello, sir.
Okay, describe your
Suturing,
episiotomy.
ma'am.
Describe your episiotomy.
Hello.
Describe your
Till
episiotomy. Okay, where do you start your sutures?
We will reverse the suturing on searching the inferior end of the incision, ma'am, and we will suture the skin layer using continuous subcuticle technique.
Okay, we start 1 centimeter above the angle and we do what? What kind of sutures?
Continuous subcuticle cutaneous technique.
Subcuticular until you reach your.
Yes. We will suture up to the fourchette and we will finish the and tie off the knot and we will check the repair we done it.
Okay, how will you check the repair? What do you have to make sure of?
There is no loss of blood and it's up to tie or fourchette.
So
We
you
have
check
to do
for
suture.
hemostasis and you check if there is no suture in your rectal vault. Why is it important to make sure that you have not sutured your rectal vault?
Because if we suture the rectal, it will make pain while pissing or something like that.
Okay, it may cause your fistula, your vesicovaginal fistula. Okay, you have checked your
Yes, ma'am.
vagina and rectum, you have checked your placenta. What else do you check for? You have checked your placenta, you have checked your vagina. What else will you check for?
Postpartum hemorrhoids, ma'am.
Okay, how will you know that there's no postpartum hemorrhage?
By inspecting it.
Okay, inspect the uterus.
Trauma.
What will your uterus, what's your uterus supposed to be? So your uterus should be
Conjugated.
conjugated or contracted. Okay, so you
Yes,
check if your
contracted.
uterus is contracted, you check for the placenta, you check for the vagina. And that is your spontaneous vaginal delivery. Okay, any questions for this SGD?
No, ma'am.
Okay, none. So good. Except for a few, brush up so that you would know the answers also. All right. Could you open your camera so that we could have a video? We could have documentation. Amit, Where's your LO? Could someone
Ma'am, Amit is not here. Yes, Dilip is taking screenshot.
what?
Yes, Dilip is taking screenshot, ma'am.
Okay, please do the screenshot and send to me. Okay, so thank you for attending this SGD. Good work, good work. I saw that some of you reviewed the previous SGD. That's fairly fine. But as you have seen, I have changed it a bit. But of course, the basics of your SGD normal delivery does not change much. So it's okay. So I commend you for reviewing stuff beforehand. Okay. So see you for our next SGD. If you don't have questions, you may leave this call. Please send the picture to me so it's a documentation of our SGD.
So
All
thank
right.
you.
Thank you.
Thank you, ma'am.